to our seminar. It is my immense pleasure to introduce today's speaker, Dr. Michael Vinikoor. Dr. Vinikoor is an associate professor in the UAB, and I'm going to read this because it's new. Marnix Heersing's UAB School of Medicine, a scholar in the UAB Center for AIDS Research and UAB Sparkman Center for Global Health. Dr. Vinikoor is, in addition to being an infectious disease physician, he's also an internist, pediatrician, and global health researcher. Over the past 12 years, he has been based mostly in African countries, Zambia, and most recently Malawi. He has mentored countless of clinicians and researchers at undergraduate, graduate, medical, doctoral, and postdoctoral level, including myself. So I'm really proud to say that. Many of his mentees also co-authored numerous of his manuscripts in high-impact journals. His own research focuses on comorbidities and co-infections in people living with HIV, mostly in Zambia, but also other sub-Saharan African countries. He received many prestigious NIH and non-NIH grants. He also serves in working groups, NIH working groups focused on HIV, hepatitis, mental health, substance abuse. And today he will be presenting on the harmful alcohol use, the next big threat to health in sub-Saharan Africa. Please help me welcome Dr. Michael Vinikoor. Thank you.
Thanks, Anna. Can you allow me to share my slides? But just as a background, thanks to the Sparkman Center for inviting me. Actually, this talk was, I think, planned for the very beginning of the COVID epidemic, and then we sort of shelved it for a while. So hopefully this is a sign that we're getting back to non-COVID issues, medical issues. And also, just as background, I'm an infectious disease doctor by training, but in the nearly 10 years I've lived overseas in sub-Saharan Africa, I've really adapted to looking at some of these non-infectious issues, which are really rising in the population and are, I think are really the future of health in this region. And so I think it's a credit to so many people who have worked on treating infectious diseases that now we can start to see non-infectious diseases arising in the population. So let's see if I can get this to, I have been having a few issues with Zoom this week. Let's see if, okay, so let me see here. I made some notes to self, so I just want to make sure I can see those. Anna, can you see my screen?
Yes, I can. Mm-hmm. And I cannot see your notes, so.
Yeah, right, we do see the presenter view that shows the slide and the next slide. It's not the regular view.
It's not the regular view.
Okay. Okay,
mean,
let's try it.
Okay,
this is good. Yeah,
this is good. Yeah.
it works perfect.
All right, great. Yeah, so my topic is harmful alcohol use, the next big threat to health in sub-Saharan Africa. And there's my email address. I'll share it again at the end if anyone wants to reach out afterward. I have no disclosures related to this presentation. And importantly, I don't have any support for my work from the alcohol industry. The learning objectives for the next 30 to 40 minutes are to recognize why rapid increases in alcohol use are happening in sub-Saharan Africa, understand the multiple ways that alcohol use can be harmful, identify some of the major barriers the health officials are facing in addressing the challenge, and become aware of UAB's new program on alcohol use and mental health, which will be soon implemented in Zambia and Alabama. Okay, so in part one, I will just tell you a little bit about what we're seeing on the ground and what's fueling it. So you may or may not be aware, but some of the fastest growing economies are located in sub-Saharan Africa. And so you can see on this list from 2018 of countries with large GDP growth, that a lot of them are in the Africa region and having, quite rapid GDP growth. And in sub-Saharan Africa, one of the actual limiting factors which keeps alcohol use in check, if you will, is poverty. And so as the middle class expands and as people's family economics are improving, there is more access to alcohol use. And so in most analyses of alcohol and socioeconomic status, you'll see that those with higher socioeconomic status have more alcohol use. So that's a bit worrying. Globally, and this is pre-COVID, during the decade before COVID, the alcohol industry was reporting that their growth rate in alcohol sales was declining, especially from late 2000s up to 2015. And 2015 was really the first year when the sale of alcohol actually reduced globally. And so this was very alarming to people in the alcohol industry. And most of the reduction in alcohol use was occurring in upper income countries, including the US and Europe. And so the alcohol industry has really pivoted a lot of its new investment into developing markets, including sub-Saharan Africa. So here's an article from 2012 reporting on SAB Miller's $2.5 billion investment in new markets in sub-Saharan Africa. And this makes a lot of sense because of alcohol epidemiology in Africa. So here's a comparison of alcohol use US versus Southern Africa, where I'm located. So you can see, first of all, the population is substantially younger in Southern Africa. The per capita alcohol use is reported to be similar between men from the US and Southern Africa, but in women, it's a lot lower at present. And then I wanted to bring to your attention these last two statistics to make you aware that actually at present, most people you encounter in sub-Saharan Africa do not drink alcohol at all. So around 70% report never taking alcohol, what we call lifetime abstinence of alcohol. And this is just for cultural or religious or family traditional reasons. Or religious reasons as well. Whereas in the US, in most surveys, about 70% say that they had at least one drink in the previous year. But when people do take alcohol, those drinkers in Southern Africa, they tend to be heavy drinkers. There's a kind of an all or nothing phenomenon. So people either don't drink or they drink to extremes. And so according to survey data, in the US, we would say about 20 to 25% of the population has unhealthy alcohol use or alcohol use disorders. So within the US, it's quite highly prevalent. But in Africa, so to get the actual population prevalence of unhealthy alcohol use, you multiply the percentage of drinkers by the percentage with unhealthy alcohol use. But in sub-Saharan and Southern Africa in particular, the majority, upwards of 80% of people who take alcohol drink at very heavy levels. And by the way, I wanted to mention that this term unhealthy alcohol use is really a blanket term that's been increasingly adopted to describe binge drinking, which is usually drinking more than 5 or 6 units per day, and chronic heavy alcohol use at levels that are above what's recommended. So this is kind of a blanket term, which is increasingly being adopted in the field. So looking at those statistics and their need to grow the market, the alcohol industry sees huge potential in Africa because you have a huge pool of non-drinkers to engage. So there's a lot of marketing going on to people who don't usually drink. So for example, women, and try and get people to start drinking for the first time because because the trend is that once people do start drinking, the typical pattern of drinking is one of excess, which would again lead to high alcohol sales. Another reason, other things that are fueling alcohol use and alcohol-related harm in Southern Africa are regulations which are lax. So in this study from the World Health Organization, they analyzed drunk driving policies in Europe versus Africa. And you can see here that in green are countries that have strong policies to prevent or to enforce laws around drunk driving. And you can see that almost no African country really has those policies in place. And the red are countries where drunk driving is really not considered a serious crime. So you can see that's a huge problem from a policy perspective. Actually, can you hold on? I'm getting a lot of background noise from a child in another room. I'll be right back. Sorry about that. And so I also wanted to point out around regulation that this supermarket survey here on the right showed that the price of a beer at the supermarket was lowest in South Africa compared to any other country that was surveyed. And I will tell you from my own experience that this survey was not focused on Africa. And if they actually went into other countries beyond South Africa, they would find even lower prices. And so you can see here that taxes on alcohol are very low in Africa due to lax regulation. Another trend which is fueling increasing alcohol use is the commercialization of the African home brew. So here, this picture on the left is a traditional brew of alcohol, usually made with sorghum, maize, or wheat. And and people would traditionally drink it out of a pumpkin or something of this nature. And this was usually brewed at home, so therefore had very low cost. And so the alcohol industry has really adopted this style of beer and learned how to make it and distribute it widely at commercial breweries. And so now at the supermarkets in Malawi and Zambia, where I spend a lot of my time, you can buy Chibuku Super, you can buy Chibuku Shake Shake there in the supermarket. And then in the community, these are sold at a very, very low prices. And so suddenly traditional styles of alcohol are now being widely distributed by these very strong distribution networks that are set up by the alcohol industry. And the other thing to note is that since it's a traditional type of drink, there's less stigma around drinking it. And so I think that also leads to a lot of people who start drinking because they sort of view this product as being a traditional cultural entity and is part of the culture here. And so therefore, it's very accepted to start drinking. And even for non-beer types of alcohol, there are also trends in a similar direction. So this data from European spirit producers reported that in 1 year, 2018 to 2019, they experienced a 31% increase in exports to Nigeria. And there are lots of other similar data like this. So this, again, this would be on the middle class, upper class end of the spectrum, who are now able to afford more expensive imported spirits from Europe. So now I just wanted to go over some of the consequences of rising alcohol and what this looks like in sub-Saharan Africa. And so as you all will be aware, once alcohol is ingested into the body, it causes a systemic and different types of effects ranging all throughout the organ systems. And so you can just have a myriad of different negative effects on the body, which is our direct cause of alcohol. But in addition, I think in sub-Saharan Africa, we also see other types of negative consequences, including road traffic accidents. And so while as I mentioned, I'm an infectious disease doctor, and I think that part of my mission is to help control treatable infectious diseases, I'm seeing rising related mortality and morbidity from road traffic accidents. And so actually, although the data are not very well captured by governments, I think most people on the ground would start to think that the main causes of death in Southern Africa are actually road traffic accident related, more than HIV, more than tuberculosis, more than malaria even. And so it's concerning that most of these accidents are actually fueled or contributed to by unhealthy alcohol use. So unfortunately, if trends continue and unhealthy alcohol use continues to increase, with no other interventions in place, we could see increasing mortality and morbidity related to these traffic accidents. And you can see this is just a table showing the comparison to the US and other countries in Europe. So, for example, I think Russia, Ireland, these are other countries in Europe where you would consider they would probably have a lot of alcohol-related problems, but instead, it's actually these countries in Southern Africa that have more alcohol-related road traffic accidents. And then I also wanted to talk about alcohol and hospitalizations. So this was picked up, I think, in the US and also by NPR and others, that banning the sale of alcohol has now become a major strategy in the fight against COVID in South Africa. And so the reason for that is that South Africa, like many of the other countries in the region, recognizes that alcohol fuels a lot of accidents, a lot of traumas from accidents at home or at work, and also fuels domestic violence and fights and crime. And therefore, a lot of these individuals end up in the hospital, filling up the hospital beds. And on top of that, you also have the patients who are suffering from the end organ complications of alcohol use, altered mental status, gastrointestinal problems, or liver problems. And so in order to make room for treating COVID-19 patients, the government did very well in banning the sale of alcohol every time there's been a COVID wave in South Africa. And so it's now happened 4 different times. And very interestingly, they were able to reduce hospital admissions in a matter of weeks after banning sale of alcohol. And then when they ended the ban, when the COVID declined, they again saw a rapid increase in hospitalizations for alcohol-related traumas and complications. And this has been a common picture in South Africa, where as soon as they announce that they're going to ban alcohol, or as soon as they lift the ban of alcohol, you get people queuing up at the supermarket to fill their carts with as much alcohol as they can afford to buy. And so I think there are a lot of lessons to be learned from this alcohol ban in South Africa. And so I'm hopeful that in the future, we'll be able to analyze how banning the sale of alcohol really altered health and other consequences like economics and others. Further, in addition to the direct effect of alcohol on the body and the indirect effect on causing all these traumas and accidents and domestic violence, alcohol also fuels infectious disease epidemics. And so this is where I come in. So it's well established that alcohol can drive the transmission of tuberculosis and HIV as well. And these being two of the most common infections, therefore, as alcohol rises, it would threaten the control of these important infectious diseases. So at this time, I just wanted to mention CIDRZ, which is a UAB collaborating institution that I work with located in Lusaka, Zambia. And CIDRZ has had a long-standing collaboration with UAB for about the last 20 years. And you can see it's a very large, well-established organization with 63 different grants from 22 different funders, including US government funding sources, and more than 500 staff members, and an average annual revenue of more than 45 million. And also you can see how integrated UAB is in the organization, because Professor Mike Sag and Professors Carolyn Bolton and Roma Chilengi are part of the board of directors and the leadership team at CIDRZ. And CIDRZ was originally established, as you can tell from the title, Center for Infectious Disease Research in Zambia. It was really established to respond to the HIV epidemic in Zambia and the region. But in more recent years, similar to to other trends, they've shifted into non-infectious diseases, including unhealthy alcohol use and mental health challenges. And so the organization is increasingly working outside of infectious disease now, just following the public health threats. And so I just wanted to present some research around HIV and alcohol, because this is really the central focus at CIDRZ when it comes to alcohol, is how does alcohol intersect with the HIV epidemic in Zambia? And so for many reasons, alcohol and HIV don't mix well together. And so those individuals with unhealthy alcohol use are at higher risk of acquiring HIV infection or being exposed to the virus. And people who are living with HIV tend to have higher prevalence of unhealthy alcohol use. And this is in part due to mental health and challenges and even self-stigma, which sometimes fuel people to take alcohol to reduce negative feelings that they're having. And so you can see in this study that CIDRZ researchers did, collaborating with other countries, at least you can see the pattern here in Zambia and Togo, that the blue columns are the prevalence of unhealthy alcohol use in people with HIV, and the orange columns are WHO country data. And by the way, this isn't overall population levels, but this is the prevalence of unhealthy alcohol use in drinkers. So as I mentioned before, most people in Zambia and most people in Togo don't take alcohol, but when they do, you can see 80 to 90% prevalence of unhealthy or risky alcohol use. And also of concern, several papers have looked at whether people living with HIV are more sensitive to the effects of alcohol. Maybe what we consider to be safe amounts of alcohol should be lowered in people with HIV. And here's one study where men with HIV said they needed fewer drinks to feel a buzz or feel intoxicated compared to men who did not have HIV. And there is some underlying hypothesis as to why that might happen. And it might be that HIV alters the gut functioning and allows alcohol to be absorbed more quickly or more to a larger degree than otherwise would happen. Further, as I mentioned, CIDRZ is increasingly looking at what we call now non-AIDS events. And so as people with HIV are treated with effective ARVs, the incidence of AIDS, which is the condition where the immune system is severely compromised by the HIV virus, AIDS becomes less common. And actually, we're seeing fewer and fewer AIDS-related deaths, such as opportunistic infections and cancer, than we have ever before during the HIV epidemic. But on the other hand, there seems to be a rise in the so-called non-AIDS events. And these are events like cardiovascular disease, chronic liver disease, chronic kidney disease, neurocognitive diseases. And it appears that people with HIV tend to have these events at a younger age than people who are living without HIV. And there are different hypotheses for that, but one is that it's inflammation related. And another is that smoking is more common in people with HIV and maybe promoting many of these events. So if you go back to alcohol, my hypothesis is really that alcohol really exerts multiple channels to contributing to these non-AIDS events, because unhealthy alcohol use alters your behavior. So for example, in the HIV context, it will reduce your medication adherence. So patients will be less effective at taking their daily medication. And this will contribute to the inflammatory cascade related to HIV, which contributes to an endpoint. And also alcohol will promote smoking. So a lot of people, especially in Zambia and Malawi, they typically don't smoke as much as you would see in the US, but alcohol tends to be when they smoke. So when they drink is when they smoke. And so this is very closely tied. And so again, that's a channel through which alcohol can contribute to the incidence of these non-AIDS events. And finally, alcohol on its own damages end organs and will contribute to these events. And so I do think that some of this epidemiology around non-AIDS events in people with HIV is really not just due to the inflammation or smoking, but is actually due to their unhealthy alcohol use. And I think this is a strong reason why screening programs and treatment programs should be strengthened in this area to reduce the negative effects of alcohol use in people with HIV. And now I wanted to talk about some of the challenges in the field when it comes to addressing unhealthy alcohol use in sub-Saharan Africa. So I think the largest challenge, which is not one that I am directly working in, but I do think it's a really important area that we all should be trying to get involved with, is alcohol policy. And so currently, alcohol policy is heavily influenced by the alcohol industry. And so that is what has exerted control of the prices, the minimum price of beer being so low. The taxes on alcohol are very low. The penalties for drinking and driving are incredibly low. And so really, policies need to be strengthened, and reining in the industry's influence on policy needs to be undertaken. At the same time, alcohol policy is a complicated space because there are a lot of jobs created by the alcohol industry, and unemployment is a huge problem in sub-Saharan Africa. And so I think that government regulators are very aware that some of these policies may have do more harm than good when it comes to people's livelihoods. And of course, in this region, so many people are living in poverty and have extreme economic hardship. And so just a slight change to their economic situation could be way more harmful than alcohol could be. So I think it is a delicate and complicated area, but very important. In my area, which is more clinically focused, I think a lot about the challenges of screening and treating alcohol use. So in the screening space, we have a lot of challenges around underreporting, and I'll talk a little bit about that in a second. And I also want to say that there are these reporting issues also affect epidemiology studies. So in the field of alcohol screening and treatment, we rely nearly entirely on surveys. So there really is a reliance on the person to admit to what they're drinking and how much. And so even in clinical trials, they usually have a survey as the outcome of the trial. And so, but we know very well that patients there's social desirability bias, where patients want to, feel that the right thing to do is to underreport or not report alcohol use. And this is especially a problem in alcohol treatment studies, because as you can imagine, after administering a treatment, if you resurvey the patient and ask them, now how much are you drinking, they're very likely to tell you, okay, I've stopped drinking. So this is a widespread problem in the field of alcohol research. And secondly, there's recall bias. And so a lot of times we're asking people to report how much they drank on when they were drinking, how many units, how many beers, how many shots of whiskey. And given that the alcohol impairs your cognitive functioning, this again leads to inaccuracy in the data. And in the African context, we have even more challenges. So for example, alcohol is sold in a lot of different diverse package sizes. And you even see some types of hard alcohol like spirits sold in small plastic sachets or in plastic baggies or in repurposed plastic bottles. And so it's really hard for patients to know exactly how much they're drinking. And thus you as a researcher struggle to know if they actually were able to reduce their alcohol use or not. Another issue is drink sharing. There's a culture of passing the bottle around. So one beer or one bottle of whiskey could be finished by 4 or 5 people. And again, how can you measure how much alcohol was consumed by your patient when they were sharing with 3 other people? And finally, there is, although much of the traditional beer and spirits have moved into the commercialized space, and more formalized and more measurable units, there still is traditional beer around, brewed at home. And there are still spirits which are more or less like what we consider moonshine in the US. And the percent alcohol by volume is unknown in these products. And so for many reasons, I find that in the field of, in alcohol research, there's really a lot to be done in understanding how to measure alcohol use. And I think that these measurement issues really undermine some of the epidemiology work around how harmful alcohol is. And that might explain why a lot of studies don't show that alcohol is harmful. And that creates confusion. But there is progress in this field of measurement of alcohol use. And so in the last 5 or 10 years, a couple of biomarkers have come out which do help us in our research with understanding the harms of alcohol use. And here's one example, the ethylglucuronide rapid urine dipstick test, or ETG. This is now widely commercially available in the US. You can order it on Amazon at about $5 per test. And basically, ETG is a metabolite of alcohol that's produced in the liver and excreted in the urine, and can be detected for up to 3 to 4 days after your last drink. So it helps you to identify people who took alcohol in the last 2 or 3 days. And we did a study with this biomarker in Zambia. And over 3 years of follow-up of people, these are people with HIV who were treated for 3 years with ARVs. We did the traditional survey of their alcohol use at each time point. And then after they completed the survey, whether or not they reported alcohol, we went ahead and asked them for a urine sample, and we did the test, and we gave them the results of the test. Yes, you have alcohol detected, or no, you don't. And then we looked at liver damage as our outcome. So ALT elevation is a marker of liver damage. And so what we learned from this study is that the group with the highest prevalence of liver inflammation over follow-up was actually the group here in maroon or red, who reported no alcohol use, and the alcohol was only detected with this biomarker. So that was very interesting. And here in blue is the group that did report openly drinking heavily. So the people who report openly, so essentially, if we hadn't used the biomarker, this group here in red would have fallen into one of these abstinence groups here, probably this green group. And so it just shows you that by having a biomarker, you can reveal a group of patients who potentially have the most dangerous drinking pattern, the most harmful one, and otherwise you wouldn't be aware of it. And this is another study which supports the same idea that patients who fail to report, who don't report their alcohol use, or who falsely report abstinence may be a very high risk group. So in a large VA cohort in the US, Similarly, researchers did a survey called Audit C, which is just a screening instrument for alcohol use. And then they took a blood sample to measure what's called PEth, phosphatidylethanol. And this group of patients where their audit C was a 0, meaning no alcohol was reported, but their PEth was greater than 8, meaning detectable alcohol in the body. Again, this group had the highest all-cause mortality in the cohort. And here down at this point, you can see the heaviest drinker category that reported alcohol use. So similar to our study in Zambia, it appears that unreported alcohol use may be really important to detect for screening and treatment purposes. I think another issue that holds the alcohol field back is epidemiological controversy over what's harmful about, at what level of alcohol use does harm occur? Because again, alcohol use is a cultural norm, and 70% of people in the U.S. have drank in the last year. So, but defining, what are healthy levels, especially for certain at-risk patient populations, is really important. And you might be aware of what's called the J curve of alcohol intake and mortality. And so some epidemiology studies, especially in Europe, have reported that as your alcohol use increases from 0 to moderate levels, defined as between 0 and 60 grams per day, this is equivalent to several drinks a day, you actually see a reduction in the risk of heart attacks. And so that's very interesting that by drinking moderately, the epidemiology data might suggest that you actually have improved outcomes. But then when you drink to heavier amounts, you have a higher risk of heart attack. And so this J curve is very controversial and has not been confirmed in every study. There are some where it was confirmed and others that didn't find this. And I would say that, many people are skeptical about this, but this is the kind of thing that helps to, create doubt that alcohol is harmful. And I think certainly in the alcohol industry, they talk about the fact that, they're not trying to promote unhealthy drinking. They're just trying to promote social drinking or moderate drinking. And they sort of hint that moderate drinking is not harmful and maybe even helpful in some cases. And so in case you weren't aware, there was so much controversy in this field that the NIH actually got involved in trying to set up more or less a definitive clinical trial in this space. And so, the NIH and some investigators designed a study to really test the hypothesis of whether moderate, i.e. low-level alcohol use was good for your health or not. And so they plan to recruit adults age 50 and over who are at high risk, who are deemed to be at high risk for heart disease. And then they would randomize these adults to either strict abstinence, or they would encourage them to have one alcoholic drink per day, and follow these people for up to 6 years, measuring heart attack, stroke, diabetes, and all-cause mortality. And so this study was, very well funded and had support from the NIH, from the NIAAA, the Alcohol Institute at NIH. But unfortunately, or fortunately, it was actually canceled because it turned out that some of the investigators involved had previously had a lot of support and conflicts from the alcohol industry. And there was also scientific concern around the study design. And there was a lot of experts in the field that felt that the way the study was set up, it was set up to really not to detect any harms from at 1 unit of alcohol per day. And therefore, there was concern that might lead to people interpreting that they should start drinking, or at least they should not stop drinking moderately. And so this came out in 2018, and it was a huge story for a couple of weeks in major newspapers. And I think it was also a bit embarrassing for the NIH because looking, as I was reading more about this study, it just seemed to be, it just seemed to be contaminated a lot by the motivations of the alcohol industry to prove that alcohol was safe or potentially beneficial to the health. So I think these controversies around moderate drinking and what constitutes moderate drinking are an issue. And even in the African context, we have no idea what to recommend to patients when we want them to cut down. So I'll shift over now to talking a little bit about our treatment challenges. So psychosocial and other basic forms of one-on-one counseling are widely available in sub-Saharan Africa. The problem is we really don't know how effective they are. And when there are evidence-based protocols for unhealthy alcohol use, but they're rarely ever used. And that is largely because health workers haven't been trained in these. And so people really aren't getting evidence-supported treatments when they do admit to unhealthy alcohol use. But there's increasing interest in this area. And I think that this is partly because alcohol is seen as a driver of TB and HIV epidemics. And as in TB control programs and in HIV elimination programs, the programs increasingly see that they need to start screening more widely and treating alcohol so that they can achieve their infectious disease goals. And so now my last couple slides, I really just wanted to introduce you all to a new research project at UAB called ZAMBAMA, Zambia Alabama HIV Alcohol Comorbidities Program. And I am leading this together with Dr. Karen Cropsey, the professor of psychiatry at UAB School of Medicine, and it's funded by the National Institute of Alcohol Abuse and Alcoholism. And I'm not going to go over all the components of the study, but just to say that in this research program, we're going to be evaluating two different treatments for unhealthy alcohol use in people with HIV. One is called CETA, Common Elements Treatment Approach, CETA, and the other is a very brief intervention. CETA is a multiple session cognitive behavioral therapy, which usually requires between 6 and 10 sessions of therapy with the same provider. And these are usually delivered over several months. And the brief intervention is actually done in one day over about 30 minutes. And so we want to test the effectiveness of these different treatment models. And we're going to be doing two different projects, one in Zambia with people with HIV and unhealthy alcohol use, and the other in Alabama. And so I wanted to move over to this slide. Yeah, and so this study really involves a lot of different investigators. And what I think is very unique about this study is that we are really going to be exploiting a collaborative approach between Zambia and Alabama and a lot of bidirectional transfer of knowledge. So as I mentioned, screening for alcohol use is really not widespread in Zambia and similar countries in sub-Saharan Africa. But if you come to the UAB HIV clinic, they have well-established what they call PROs, or patient-reported outcomes, which is to screen patients for psychosocial issues, including substance use. And so through this ZAMBAMA project, we're really going to try to transfer the expertise of people such as Alan Eaton, Mike Magavero, over to Zambia so we can learn how to integrate this into routine HIV clinical care. On the other hand, the CETA intervention was actually originally designed for use in low-income settings. Although it requires, it's quite a rigorous cognitive behavioral therapy protocol. It was designed in a way that even people with only 9th grade education in low-income settings can learn to deliver it. It uses a very logical approach, and the team that we're working with, led by Laura Murray from Johns Hopkins, has used this successfully in about 9 different low-income countries. And so really building on several CIDRZ studies we've done in Zambia, our team from Zambia is actually going to come over to Alabama to train providers in Alabama and set up the monitoring and supervision systems for Alabama. So that's, it's a wonderful exchange of information between the Alabama side and the Zambia side. And I don't have time to go through everyone involved in the study, but you can see, we have a lot of different investigators involved. And although at the heart of the study, we're going to be evaluating this brief and complicated or complex treatment intervention, we have a lot of other scientific goals, including biomarker work, including health economics work. And so if anyone on this call is very interested in getting involved in this project, we have very ambitious goals to really try to tackle a lot of important issues in the field of HIV and alcohol use. Sorry, that was I wasn't expecting to take so long, but I finally reached my last slide, and really appreciate everyone staying on the call for the full time. And yeah, happy to take any questions and comments that people might have. Thank you very much.
Yeah, thank you so much, Dr. Vinikoor. My name is Janet Turan, and I'm the director of the Sparkman Center for Global Health, and have had the pleasure of working with Dr. Vinikoor over several years now in different capacities. And so we're so excited that he could share this work. If people do have questions that you want to type in the Q&A, I will try to send those along to him. And I just wanted to start off with a quick question about sort of what you have seen in terms of the stigma or social judgment around drinking in I guess probably in Zambia is probably the place you know best. How do people perceive people who drink, and what are maybe provider attitudes toward people who have unhealthy alcohol use?
Yeah, thanks for the question. Yeah, I think that people who come to the clinic, smelling of alcohol, or they look like they've been drinking, I think they do experience worse treatment. I think that there is some level of judgment that heavy drinking, even though it's widespread, is really at the clinic is really seen as a problem. And I do think that patients probably are less likely to come to the clinic after they've been drinking, because they are afraid of being stigmatized or harassed or discriminated against by the staff. And so I think that in some of our work, we were trying to understand why it is that the patients who drink heavily have issues with adherence and retention on their HIV treatment. And it might be that every morning they wake up hungover and they struggle to get out of the house to go to the HIV. And then when the HIV clinic arrives, they are just afraid to be found out about their alcohol problem. And so they decide to postpone the visit, and then they end up skipping doses of medication. So there is something there around stigma. I don't completely understand it, but yeah, I do think certainly the staff don't consider, intoxication to be like a medical problem. They really see it as a behavioral problem, I think. And so I do think there is some.
We have, similar challenges around maybe more illicit drug use and substance use in the US with patients facing a lot of judgment and challenges with providers around that issue. So there's certainly some connections there. I see, so there are a couple questions. One person is asking to share the source for a specific slide, but I'm not sure which slide they're referring to. But
I believe it was the slide with the prices across different countries.
Yeah, okay, maybe you could get the email address of Nino, and then I can email Nino that later.
Okay. And I see one that says from Amy Day, in studies where the J curve was not considered valid, what patterns were found instead? Are you, I don't know, I guess what different, if they didn't confirm the J curve?
Yeah.
Mhm.
I mean, alcohol epidemiology studies are very complicated to pull off because even people who report not drinking, they may have stopped drinking one day ago. And so therefore their bodies and their outcomes are going to be different than someone who never drank in their life. And so a lot of studies will actually exclude people who report abstaining, and they'll just try to compare light drinking, moderate to heavy drinking. And a lot of times those studies were the ones where they actually showed that there's just a linear or exponential relationship between alcohol and all of these outcomes. And so, yeah, I hope that sort of answers your question, but I've really struggled with this. I'm not an epidemiologist, but it's an area where I think there's a lot of interesting issues in analysis. Over.
Thank you. Yeah, feel free to pop in with any more questions.
There-
Go ahead.
Oh, there are 2 questions in the chat.
Oh, in the chat. Oh, I failed to look in the chat. There we go, chat.
Yeah, I see a question from Lynn. Are we going to include pregnant women? And yeah, I don't think we specified. That they would be excluded, and therefore they would be eligible for the new trial. But I don't think we didn't have any specific focus on pregnant women who who have HIV and unhealthy alcohol use. But yeah, it might be something worth looking into, to potentially to have like a target for a certain to enroll a certain number of women, and potentially stratifying so that we make sure to randomize them appropriately into each arms equally. Okay, and I see a comment from Erica. Can you speak to implementation component? Yeah, so we do work with some of the policymakers, both in the HIV program and in the alcohol policy department at the Ministry of Health on this study. And so actually Zambia, where the study will take place, did create its first ever alcohol policy about 1.5 years ago, just before COVID. And so that was, that's a step in the right direction in recognizing the problem. And really within most of our policy discussions have been around how to screen within HIV clinics. And so we try to highlight alcohol in the HIV guidelines. We try to we try to identify opportunities to do analysis with local, with policy leaders or local health program officials, so that we can raise awareness of the problem. Yeah, and then there's a question about finance, commerce. Yeah, it's really very interesting, and actually I personally feel that although I think what we're doing is good, I think working in the alcohol policy space has potentially more impact because I think the South African experience shows us that probably limiting or raising the price or banning the sale of alcohol or restricting it would probably have way more public health impact than scaling up, screening and treatment centers. So I think that, yeah, I think I would be interested in getting involved in that, but I don't know very much about alcohol policy and economics, but I think it's a really important area.
Great. Thank you. I was wondering, was there something like that happened? What got you interested in working on this topic in particular? Was there something that you saw that really caused you to because it's a little bit it's different from what you were doing previously.
Yeah, no, it was really just the clinical care angle. I mean, as you're interested in liver infections, viral hepatitis.
Right.
And so I was seeing a lot of patients where we were giving them the appropriate antiviral medication, but their liver disease would persist, and they were drinking. So I really said, well, I might be able to, my hope is to reduce their liver disease to the point where they won't die of cancer or cirrhosis. And if they're continuing to drink, that is undermining my clinical goal there. And so, so when I started to see that this was so widespread, I just started to look around to find partners in this area. And my collaborators from Johns Hopkins, they were at the same time working with trauma populations, like intimate part survivors of
Oops, looks like got frozen.
Oh, sorry. I think I dropped off there for a second, but yeah. Thanks for your question. It's a long story, but I think you got the message that.
We got the essence of it.
Yeah. Essentially, it was really just the needs to find a treatment for the patients, really.
That's great.
Yeah.
Okay, well, I think our time is up, and we really want to thank you so much. This was a great talk, and I think there's obviously a lot of interest, and thanks for sharing your emails so people can get in touch if they want to learn more or collaborate. So but thanks so much for sharing that and spending some time with us. Thank you.
Thanks a lot for inviting me. Talk to you guys soon.
Okay, bye-bye.